Now, if you flex the knee to 90 degree, the condition will be extremely painful because you are further compromising the space available in the knee. But if you flex it to 20 to 30 degree, there will be increase in the space, so that amount of the blood could be equilibrated inside the knee joint. So the condition will be less painful. The another test is anterior drawer test. Now, under the heading of anterior drawer test, what is the difference in between the two? It is performed with 90 degree of knee flexion. And remember, anterior drawer test is the kind of the test which should be avoided. Means you should not perform this test immediately after injury. It has to be avoided. All right, avoided immediately or in acute injuries. All right, this is the kind of the test that is needed to be avoided in acute injuries. That is all about the test for the anterior cruciate ligament injury. Now, as far as the management, that means treatment of the complete tear of the ACL is concerned, that treatment would be based on arthroscopic reconstruction. Arthroscopic reconstruction. Now, what do you mean by the term arthroscopic? That means you are not going to open the joint just by the placement of the probes, just by the placement of the camera. You are, and by the insertion of the instrument, you are going to reconstruct the anterior cruciate ligament. You cannot repair the anterior cruciate ligament. You know, there is a difference. Repair means you pull up the proximal and the distal fiber and you suture them together. That will be a repair. Repair is impossible. You have to reconstruct it. Now, reconstruction means you have to take up any of the tendon, blend it in a fashion of converting it into an anterior cruciate ligament, and then attaching it proximally and distally in the direction of the torn ACL. That is reconstruction. So your question is that out of the multiple tendons in the human body, which one is most commonly used? Donor tendon for the purpose of graft in arthroscopic reconstruction of ACL. So donor tendons which are most commonly used for the purpose of reconstruction, it is semitendinosus and gracilis. You know, gracilis and semitendinosus are the most commonly used tendon for the purpose of this reconstruction. Although there are other tendons also, like patellar tendon was used, other hamstrings can also be used, even the peroneae can be used. Means any of the tendon could be used as a donor graft. But in order to have it more feasible, which is very easily isolated and is considered to be a thick, stable, tensile kind of a graft, which is taken by the combination of both semitendinosus and gracilis. All right. So this is all what you need to remember about the anterior cruciate ligament. Now, exactly opposite, although to some extent, but relatively opposite, is the discussion of the posterior cruciate ligament injuries. Now, what happens in posterior cruciate ligament injury? What are the attachments of the posterior cruciate ligament? So if we talk about the proximal attachment, yes, no doubt it will be there in the femur, but where? It will be located in the anterior half of lateral surface in medial femoral condyle. All right. So this is where the posterior cruciate ligament would be attached. Anterior half of the lateral surface in the medial femoral condyle. That is the proximal attachment. And as far as the distal attachment is concerned for the posterior cruciate ligament, is the posterior to the tibial spine on tibial plateau. As I told you that this tibial plateau is having a bony projection in the form of a tibial spine. One ligament is attached anterior to this, is known as anterior cruciate. One ligament is attached posterior to this, is known as posterior cruciate ligament injury. All right. So posterior to the tibial spine on tibial plateau. So this is about the posterior cruciate ligament injury that you have to remember. All right. So once we have talked everything related to this anterior and the posterior cruciate ligament attachments, now is the time to have a discussion on the tests for the posterior cruciate ligament injury. You know, it will be a posterior drawer test. All of you know what the drawer is. You know, in case of a table, we are having a drawer. So similarly, if you flex the knee joint to 90 degree and try to force it to move posteriorly, if there is a greater translation achieved compared to the normal, that means posterior cruciate ligament is injured. So posterior drawer by keeping the knee joint flexed up to 90 degree. That is the test for posterior cruciate ligament injury. What is the major function of the posterior cruciate ligament? It is to prevent posterior translation of tibia. You know, Anterior translation of the tibia was prevented by anterior cruciate ligament. Posterior translation of the tibia is prevented by posterior cruciate ligament. And finally, the treatment. As far as the management of this condition is concerned, it is treated by either arthroscopic reconstruction, but remember one thing. If there is an isolated injury to the posterior cruciate ligament, in majority of the cases, it is not the indication to go for surgery alone. Means hamstrings can be rehabilitated to take up the action of the torn posterior cruciate ligament. All right. So in case of isolated injury to the posterior cruciate ligament, it is not entirely the criteria that you have to go for the surgical reconstruction. Hopefully you have understood. In case of ACL injuries, yes, you have to go for surgical reconstruction, but for PCL injuries, it is not very much required because hamstrings can be rehabilitated to take up the action of the PCL. Next, as far as menisci are concerned, so first of all, try to understand what is the function of the menisci, and then we will be having a discussion on just the basic management as well as the common variety which is likely to get injured. Now, before we talk anything related to this meniscus, let's talk about the meniscus. Now, there are two types of menisci. One is medial menisci and the other one is lateral menisci. Now, imagine this is the tibial plateau. Now, over the tibial plateau, we are having two cups which are holding the distal femoral condyles. One on the medial side, other one on the lateral side. That is, on the medial side, we are having medial meniscus. On the lateral side, we are having lateral meniscus. So, these are the menisci. If you look at the cross section of this menisci, then this is how the medial meniscus looks like, while this is how the lateral meniscus looks like. All right. That means the diameter of medial meniscus is more compared to the lateral meniscus, but the surface area which is encroached by the medial meniscus is lesser compared to that of the lateral meniscus. Now, as far as the attachments of these two menisci is concerned, the medial meniscus is attached to the capsule in its entire periphery. So, medial meniscus is completely enclosed by the capsule. It is having a complete capsular attachment. All right. There is a presence of the medial meniscus and it is attached to the capsule in its entire periphery. And the medial meniscus is also attached to the medial collateral ligament. It is also attached to the medial collateral ligament. While the lateral meniscus is also attached to the capsule, capsular attachment is also there in case of lateral meniscus, but the posterior margins, the posterior margin of the lateral meniscus is free. It is not having any sort of attachment. Why the posterior margin of the meniscus is free? Because it is providing a space for the popliteal tendon to move in between the posterior border of the lateral meniscus and the capsule. All right. So it is less attached. Moreover, it is not attached to lateral collateral ligament.